All right, well, I think we'll go ahead and get started at 7:30. So good morning, everyone. Welcome to Geriatric Grand Rounds. Thanks for joining us. A few announcements before we get to today's presentation. Our next Grand Rounds will be April 15th. Our presenter will be Dr. Christine Azelby, one of our geriatric fellows, and she will be talking about myelodysplastic syndrome in older adults. Our next journal club will be April 8th, and that will be led by Lauren Schneider and Sarah Beck. Other announcements, there is a division meeting after Grand Rounds today, so faculty, please join on to that after Grand Rounds finishes. You will receive an email later today with a link to a recording of today's presentation and slides, as well as a link to an online evaluation. So if you could please take a moment to fill that out, that would be much appreciated. During the presentation, you can submit questions in the Q&A or the chat box anytime, and we'll have time for those at the end. So we actually have two speakers today. This is our annual new drug update that our clinical pharmacists give every year, one of our most popular Grand Rounds. So we're so appreciative to both Dr. Linnebur and Dr. Pearson for doing this. Most of you know them, but briefly, Dr. Sunny Linnebur is a professor at the University of Colorado Skaggs School of Pharmacy and Pharmaceutical Science and geriatric clinical pharmacist in the Seniors Clinic. Dr. Scott Pearson is an assistant professor at the School of Pharmacy and practices at the Seniors Clinic on the Anschutz campus, as well as our Lone Tree Medical Center practice. And many of you know him from doing his residency here with us, and then he joined us as faculty. So we're so glad to have him in the clinics. So I'm going to turn it over to first Dr. Pearson and then Dr. Linnebur for the new drug update.
Thank you.
Yeah, thank you, Carrie. And thank you all for joining us here this morning. So for this talk, we're really going to be giving kind of an overview of what we view as some of potentially the big ticket drugs that were approved here within the last year. That's kind of what our objectives for the talk here are listing, but specifically to give you a little bit of an overview of how we chose these medications. So we took a look through the FDA website of medications that had received approval during the year 2020. We cheated a little bit. We did end up using a medication or two that were planned to be approved in 2020, but ended up being approved in early 2021. But 2020 was also a little bit of an interesting year because we had several medications that actually received emergency use authorization through the FDA for COVID treatment, and then also our vaccines for COVID. We decided to exclude these medications and really only use the medications that actually had received complete FDA approval. But in looking through these medications, we were really focusing on those that we expected were most likely to have an impact on care of older adults. So without further ado, really wanted to just give you an overview here of the medications that we'll be discussing, and I'll just give you a moment to kind of look through those and get an idea of our talk for today. All right, so it's unfortunate we don't have video for all of you today. I think if we did, we'd probably be seeing some confused faces. And that is because these are actually not the medications we'll be discussing today. Because it's April Fool's Day, Sunny and I thought that we would include a little bit of pharmacy humor here. These medications are actually all medications that have been withdrawn from the market due to safety concerns, and that's what all the indications that were listed for was the reason they were withdrawn. And given that this is a new drug update, these medications are actually quite the opposite. They're very old drugs. I think just about all of these medications were actually already off of the market before I started pharmacy school. So with that in mind, I need to give Sunny a shout out for throwing this together and giving us a little bit of that historical perspective for some of you who are maybe a little bit more seasoned in practice. But moving on, these are the medications that we will actually be discussing today. I'll be kind of leading you through the first two of these medications, and then I'll turn things over to Sunny to kind of close things off. So with that in mind, the first of those medications is Remdesivir. So Remdesivir, I'm sure many of you are already familiar with, but it was FDA approved in November of 2020, and it was approved for the treatment of patients hospitalized with COVID-19. It is an antiviral agent. It works by inhibiting the SARS-CoV-2 RNA-dependent RNA polymerase and essentially works by inhibiting viral replication. So Remdesivir is kind of interesting because it's a medication that's actually been around for a little while. It was initially developed for hepatitis C and RSV treatment, but really didn't show much promise in that area. So it was actually also then studied for Ebola virus, but in this area, it also didn't really show much benefit. So this was a medication that was really just kind of sitting around, kind of waiting for its time. So it's what I might call a late bloomer. And it happened to be one of the medications that ended up being studied for COVID-19. Now, in terms of dosing, it is an IV medication. So it's dosed as 200 milligrams IV on day 1, followed by 100 milligrams IV daily following. And generally, treatment will be for 5 days. If patients are discharged from the hospital sooner, then treatment courses can be shortened, and they can also be extended up to 10 days if patients are not showing improvement. There is limited evidence in patients who have a creatinine clearance of less than 30, not a contraindication, just an area where we don't have a lot of evidence. And then finally, I did want to just draw your attention to the cost. For a 5-day treatment course, this is according to LexComp, but the cost is close to $4,000. So although patients will be receiving this while in the hospital, it is just worth noting that it is a fairly costly medication at this point. In terms of drug interactions, you can see that remdesivir is a substrate of several CYP enzymes as well as transporter proteins. And in addition to this, it's also a weak inhibitor of CYP3A4 as well as 2 of these OAT transporter proteins. Now, at this point, we really don't know a lot about the clinical relevance of any drug interactions. There have actually been a couple of articles that have been published kind of hypothesizing different drug interactions, but there really haven't been any PK studies conducted looking at this that you might see with a more traditional medication. And so this is something that we'll likely find out more about in the future as we see greater use, but some potential drug interactions to be aware of. Now, in terms of other precautions, it is recommended to consider discontinuing remdesivir if patients develop ALT elevations more than 10 times the upper limit of normal. And as you can see in the side effects listed here, that is one of the potential risks, is that you can see increases in LFTs. Another potential side effect listed is prolonged PT. And with this one, in the studies that we're going to discuss, there really hasn't been any greater risk of bleeding seen with remdesivir. So not entirely clear if there's a whole lot of clinical significance here, but there have actually been a couple of case reports published looking at warfarin drug interactions in patients who are on remdesivir having increases in INR. So again, not something that we know a ton about yet at this point, but a potential consideration if patients are on warfarin while taking remdesivir. So in terms of clinical evidence, there are 2 studies that I'm going to be highlighting here out of about 5 studies that have actually looked at remdesivir so far. But the first of these is the WHO Solidarity Trial. Now, this was a study, it was an international open label randomized controlled trial. It included over 400 hospitals in 30 countries, so a pretty large group of patients who were included. And remdesivir was actually just one of the treatments that was studied. They also looked at hydroxychloroquine, lopinavir, and interferon. And they looked at all of these medications in patients who were hospitalized with COVID-19. Now, patients received either of these treatments compared to the standard of care, as opposed to the treatments being compared to one another. And the particular remdesivir arm, along with the standard of care it was compared to, included just over 5,000 patients. Now, for this study's primary outcome, they looked at in-hospital mortality. And again, they had these 4 pairwise comparisons, in this case with remdesivir to the standard of care. Now, when we look at our older adult population, they were reasonably represented in this study. About 20% of the patients in this study were 70 years of age or older. And because, as I mentioned, this included patients across 30 different countries, they did have a pretty broad distribution of both races and ethnicities. But now as we look at the results here, again, for that primary outcome, we had in-hospital mortality. And as you can see, rates of this were about 11% in each group. And in terms of the rate ratio, there was not a significant difference between remdesivir and the standard of care with regard to that primary outcome. Now, they did look at a couple of individual subgroups to see if there were potentially populations who may be more likely to benefit. First, looking at patients who were not mechanically ventilated at the time of enrollment. You can see among these patients, there was a stronger trend favoring remdesivir, although still not a significant difference. But on the flip side, When we looked at patients who were mechanically ventilated, you can see that the trend is actually in favor of the standard of care, showing that remdesivir really did not seem to be benefiting those patients. And so although by and large this was a negative study with regard to that primary outcome, this is just a little bit more hypothesis generating that some of those patients who were not mechanically ventilated may have benefited more. Now, as a secondary outcome, this study did also look at time to discharge and did not find any difference between remdesivir and placebo groups in this study. But it's also worth keeping in mind this was an open label trial. And so with that in mind, it's not really the best way to assess time to discharge, given that the investigators were aware of which treatments patients were receiving and may have been more likely to keep patients in the hospital to receive therapy. So this wasn't the best way to necessarily answer this question, but again, this study essentially showed that there was no mortality benefit with remdesivir. The second study that I want to highlight is the ACTT1 trial. So this was a study, it was randomized, double-blind, and conducted across 60 different sites in multiple countries. It had just over 1,000 patients who were also hospitalized with COVID-19 and had evidence of lower respiratory tract infections. These patients also received remdesivir for up to 10 days, and this was compared to patients receiving placebo. In this study, in contrast to the Solidarity trial, their primary outcome was looking at time to recovery, which they defined by either discharge from the hospital or patients being hospitalized purely for the purposes of infection control. Now, a couple of notes in terms of the population in this study, the mean age was around 59 years. In terms of distribution of races and ethnicities, because again, this was conducted across multiple countries, distribution was fairly broad. There are about 50% of patients who were white, 20% Hispanic, 20% African American, and around 10% Asian. And in terms of male to female, there were about 65% male compared to 35% female patients in this study. But when we look at their primary outcome, which again was cumulative recovery or time in hospital before recovery, the x-axis here shows time in days, whereas the y-axis shows the proportion of patients who had recovered during this time period. As you can see, at the end of this 29-day treatment period, or measurement of treatment effect, I should say, patients who received remdesivir had an improved rate ratio of recovery with an increase of about 29% compared to placebo, and this was a significant difference. Now, they also looked at the median time to recovery, which was about 10 days in the remdesivir group compared to 15 days with placebo. Now, this study did also assess mortality as a secondary outcome, and when they looked at mortality at day 29, they showed that there was a trend favoring remdesivir when it came to mortality, but as you can see, the p-value here is not significant. The confidence interval across is 1, and so this was not a significant difference, but it's also worth noting that the study wasn't powered to assess mortality. So again, the study did reach its primary outcome showing differences in hospitalization time, but with mortality did not quite reach that effect. Now, it is interesting that this study also included some subgroup analyses looking at those patients who may or may not be more likely to benefit. And in this study, they saw that the greatest benefits were found in patients who were requiring standard supplemental oxygen at the time of enrollment. You can see their recovery rate was at 1.45 in relation to placebo. And also, when they looked at death at day 29 among this population of patients, there actually was a significant reduction in mortality. You can see the hazard ratio of 0.3. Now, when they looked at patients who were not requiring supplemental oxygen, you can see that there was a trend favoring those receiving remdesivir, although not significant, but it's also worth noting that there were a pretty small number of patients who were not on oxygen in this study, with only 138. So we may not have had enough patients to really fully assess this question. But finally, when they looked at patients who were receiving high flow oxygen or those patients who were mechanically ventilated or on ECMO, these populations really didn't show any benefit whatsoever with either time to recovery or mortality. And so kind of similar to what was seen in the Solidarity trial, these were the patient populations that really didn't appear to benefit. But it is worth noting that in this current study, the study was not powered for these subgroup analyses. So again, this is a little bit more hypothesis generating. Now, in terms of adverse events, you can see here, at least numerically, for serious adverse events as well as respiratory failure, rates appeared to be numerically lower with remdesivir actually compared to placebo. And then the one other side effect of note I wanted to bring up was transaminase increases. So as we touched on earlier, this is a potential risk with remdesivir, but as you can see in this study, numerically, there were actually higher rates with placebo. So although this is something that does need to be monitored for, it's not a strong contraindication that in patients with hepatic dysfunction, it can't be used. It's just something to keep an eye on and monitoring. So with both of these studies in mind, where does remdesivir fit in therapy? So the big takeaway was that it did reduce the length of stay for patients hospitalized with COVID-19. And although we can kind of talk about that subgroup analysis, by and large, there really has not been mortality benefit shown at this point. So we really can't make that claim with this medication. And it's really a reduction in hospitalization time that we're looking at if thinking about adding on therapy. Now, the benefits do appear to be the greatest in patients who are not mechanically ventilated, but who are on supplemental oxygen. So those are the patients who would likely be most likely to really have that benefit from therapy. But it is worth noting that there is a pretty substantial cost associated with it. And so although it is the medication that will be received in the hospital, the patient might not directly see the cost, just something worth also keeping in mind. Now, the NIH has a set of COVID-19 treatment guidelines that have been updated quite frequently over this past year, and they do address the treatment of remdesivir as well. So first, in patients who are hospitalized but not requiring supplemental oxygen, they state that there are insufficient data to recommend either for or against remdesivir use. And that's based on what we just looked at with a study that really didn't have a very large number of patients who were not on oxygen. And so, although these patients may or may not benefit, we just really don't know enough yet at this point. Now, for patients who are hospitalized and requiring supplemental oxygen, again, this is the population where remdesivir really is recommended, whereas those who are mechanically ventilated or on ECMO, remdesivir really has not shown any benefit and would not be recommended. So with that, we are going to transition away from COVID-19, which I'm sure many of you are relieved to hear. And we'll be shifting gears here to talk about bempedoic acid. Now, bempedoic acid is a medication that was FDA approved in February of 2020 for patients who have heterozygous familial hypercholesterolemia or ASCVD and require additional LDL cholesterol lowering. Now, bempedoic acid is kind of a first in its class medication. It works as an adenosine triphosphate citrate lyase inhibitor, and essentially it works by inhibiting cholesterol synthesis. So if you take a look at the diagram on the right side of this screen here, you can see that bempedoic acid works kind of upstream from the target of action of statins within this cholesterol synthesis pathway, but works, again, on this same pathway to help reduce the production of cholesterol. Now, the recommended dosing is 180 milligrams daily. There is rather limited experience with patients who have an eGFR of less than 30, and it really hasn't been studied at all in either dialysis patients or patients with severe hepatic dysfunction. Again, in relation to cost, for a 30-day supply, according to LexiComp, the cost is around $400, which compared to remdesivir appears to be just a steal, but still is a substantial cost. But there is actually a medication that combines bempedoic acid with ezetimibe, and it appears that this combination tablet actually has about the same cost. Now, when it comes to drug interactions, there are two in particular that are of potential consideration when using this medication. So it's recommended that patients who are on pravastatin not be on any doses higher than 40 milligrams a day, or simvastatin greater than 20 milligrams a day if they're on bempedoic acid, based on bempedoic acid inhibiting an OAT transporter protein. Another precaution that really wanted to kind of highlight here is related to tendon rupture. So specifically, the package insert calls out rotator cuff, biceps, and Achilles tendons. And as you can see at the bottom of this slide, the incidence of tendon rupture in studies has appeared to be very low at 0.5%. But the package insert does call out that there are particular risk factors that might put someone at a higher risk of this side effect. And those include age greater than 60 years, use of steroids and fluoroquinolones, kidney failure, or prior tendon disorders. And I think this is particularly worth mentioning because as we're going to touch on with a couple of the studies that have looked at bempedoic acid, although they have had some older adults in these studies, there have been really very low numbers of patients who are above the age of 75, and some of maybe our more frail patients. And so this is a side effect that does make me a little bit concerned and something that I would like to know a little bit more about. But in terms of other side effects, gout development was seen in about 2% of patients, but in patients who had a prior history of gout, rates were at about 11%. And additionally, patients who experienced hyperuricemia, this was seen in about a fourth of those patients receiving therapy. So when we look at bempedoic acid, this is probably a medication that you would want to avoid if someone actually has a history of gout. So there are two studies that I'm going to highlight again with this medication. The first is the Clear Harmony trial. So this was a randomized double-blind parallel group study. They included just over 2,000 patients who had a history of ASCVD or history of heterozygous familial hypercholesterolemia. Now, these patients were on maximally tolerated doses of statins and had LDL cholesterols that were elevated above 70 milligrams per deciliter. And as you can see, they were randomized in a 2-to-1 ratio to either bempedoic acid or placebo, and they were then followed for a 52-week period of time. Now, for the primary outcome, they looked at overall safety, which was assessed by adverse effects as well as changes in lab values. Now, as we look at the population, the average age of patients was around 66 years, but as I kind of touched on earlier, only about 15% of patients were over the age of 75. So although this did include some older adults, probably not some of the more frail or patients above 80 that we often see in clinic. When it comes to the baseline LDL, patients had a baseline LDL around 100 milligrams per deciliter. But in this study, it is worth noting that about 75% of patients were men, whereas about 96% were white. So really not a lot of diversity from that standpoint when thinking about generalizability. But in looking at that primary outcome related to adverse effects, you can see that patients in this study overall had pretty high rates of adverse events. Rates were about 78% for any type of adverse event, although no difference between bempedoic acid and placebo, and also no differences when it came to serious adverse events that were around 14% in each group. But when we look at the adverse events that led to medication discontinuation, you can see that there was actually an increase in these events in patients with bempedoic acid at about 11% compared to about 7% in the placebo group. And then when we look at some of the specific adverse events, as we touched on earlier, the risk of gout does appear to be rather real with this medication. Although the incidence is fairly low at 1.2%, this was a significant difference compared to placebo, and also possible that given this was only a 1-year trial, that we might see higher rates if we were to follow these patients for a longer period of time. You can see that the average increase in uric acid levels was about 0.7 within that bempedoic acid group. And it's also worth noting, when we look at changes in creatinine level, there was a significant increase in this change in creatinine levels for patients on bempedoic acid compared to placebo. But with this, a little bit questionable as far as what the real clinical significance is, with only an average increase of about 0.02 milligrams per deciliter. Now, the study did also look at changes in LDL cholesterol levels. So the x-axis here is showing our time in weeks. The y-axis is the mean LDL cholesterol. And you can see the blue curve here is depicting patients who received bempedoic acid. So there, over that 52-week period, there was about a 13% reduction in LDL cholesterol. And this medication did also appear to reduce hsCRP levels. Now, finally, this was a little bit more of an exploratory outcome, but the study did also look at cardiac events, which in looking at the first line of this table here, you can see rates of overall adverse cardiac events were around 4.6% in the bempedoic acid group compared to 5.7% with placebo. And while this was not a significant difference, the study also was not powered to really detect differences in cardiac events. And so in the future, there is actually a study ongoing right now that will be assessing this. But at this point, we just don't really know enough to say whether or not there are cardiac benefits or not. Now, the second study that I want to touch on related to bempedoic acid is shown here. This was also a phase 3 trial, and it was a randomized double-blind study. It was a smaller population that was included, so they had just over 300 patients. These patients also had a history of ASCVD, heterozygous familial hypercholesterolemia, or they could have had multiple cardiovascular risk factors for inclusion. Now, these patients were also on maximally tolerated statins and also had elevated LDL cholesterols. In this case, it was elevated above 100 milligrams per deciliter. But in terms of the intervention, something that was a little bit different about this study was that they actually had 4 treatment arms. So they had the bempedoic acid arm. They also randomized patients to ezetimibe, the combination of bempedoic acid with ezetimibe, and placebo. And for this particular study, the primary outcome that they looked at was the percent change in LDL cholesterol after 12 weeks. Now, looking at this population, the average age was around 64 years. They didn't report specifically on how many patients were over the age of 75, but would anticipate likely fairly similar to the previous study. In terms of baseline LDL cholesterol, this was around 150 at the time of enrollment, so a little bit higher LDL cholesterol levels seen here. There was a little bit better distribution of gender within this study, with about half and half male to female. And when it came to race and ethnicity, it's still around 80% of patients were white in this study, but a little bit of a more broad variety of races and ethnicities. Now, when we look at the primary outcome, looking at change in LDL cholesterol, on the y-axis here, this is looking at the percent change in LDL compared to baseline at week 12, whereas across the x-axis, you see the individual treatment groups. So first, in looking at the ezetimibe treatment arm in light green, you can see there was about a 23% reduction in LDL. Next to the right, you see the bempedoic acid group with about a 17% reduction, fairly similar to what was seen in the previous trial we discussed. But what is interesting here is we do appear to see an additive LDL reduction when we combine ezetimibe with bempedoic acid. So in this case, there was about a 36% reduction in LDL cholesterol. Now, this study also looked at changes in hsCRP, which I kind of mentioned briefly with the previous study, but this is an inflammatory marker that is kind of hypothesized to correlate with potential cardiovascular benefits. It's something that statins have been shown to reduce and might lead to some of their kind of anti-inflammatory pleiotropic effects. So as you can see in this figure, ezetimibe led to about an 8% reduction in hsCRP, whereas bempedoic acid in blue led to about a 32% reduction. And again, we saw a little bit of an additive effect when we combined the two medications. So this is certainly just a surrogate outcome. And again, we're kind of waiting at this point for an actual cardiovascular outcomes trial to assess this, but these results suggest that there potentially could be some cardiovascular benefits seen. We'll just kind of have to wait and see in the future. So with this in mind, thinking about where bempedoic acid fits in therapy, these studies have shown that it leads to LDL cholesterol lowering in addition to statin therapy in some of our higher risk patients, and it has been combined with ezetimibe in certain cases as well. I didn't touch on this in the studies that we highlighted, but there is actually some additional evidence in patients who are statin intolerant, so this might potentially be a population who could also benefit from this medication. But when we look at where it fits in terms of kind of potential benefits, really we've seen pretty modest LDL cholesterol reduction, so only about a 15 to 20% reduction. And when we look at potential adverse events, these do appear to be potentially concerning. I mean, the risk of gout definitely does appear to be real. And what concerns me a little bit more that I think I would need to know a little bit more about specifically for our population is the risk of tendon ruptures. Again, given that those studies really didn't include a lot of some of our frailer, older patients, something that, it would be nice to see a study that actually looked at specifically treatment in older adults to see if this really is of concern. But then probably the biggest thing is that at this point, we just don't have cardiovascular outcome data. So we're likely to find out a little bit more in the future about this as time goes along. So now finally, just to touch on a few potential patients who you may or may not consider bempedoic acid in. The first is a 75-year-old man with a new MI, no history of cholesterol-lowering therapy. This is a patient who certainly should be on a statin. It really doesn't have a place in therapy for bempedoic acid at this time. In terms of thinking about this in the future, potentially if the patient hasn't received adequate LDL cholesterol lowering on maximal statin, but at this point, no reason to think about adding this medication. The second is a patient who is an 83-year-old woman, no ASCVD history, and she recently stopped her statin due to muscle complaints and has an LDL cholesterol of 120. So in this patient, given that it's for primary prevention, she doesn't even necessarily have the strongest indication to continue a statin. Again, really no reason to add on bempedoic acid in this case, and also we really don't have any of the data about cardiovascular outcomes at this point. Next, we have a 68-year-old woman who has coronary artery disease on atorvastatin 80 milligrams a day and ezetimibe 10 milligrams daily and has an LDL of 85. So this would be a patient you potentially could think about bempedoic acid in. It's likely to give you enough LDL lowering to get the LDL to the target of less than 70. So this would potentially be a case where you could think about therapy. But then finally, if this patient were to have an LDL of 165, probably not a case where we would think about bempedoic acid because it's really not going to give you enough lowering, and you might want to think about a PCSK9 inhibitor instead. But with that, I am going to turn things over here to Sunny to tell us about vericiguat.
Thank you. All right, and it looks like we have some questions in the chat, so we will get to those at the end of the presentation. And as Dr. Pearson mentioned, I am going to talk about vericiguat, or one of the new agents that we have for heart failure. So when we think about all of the heart failure options, there are now quite a few, and it feels kind of intimidating on which agent to choose. So I'm going to first talk about Verquvo, or vericiguat, and then I'll talk about where it fits into therapy. Vericiguat was one of the ones that Dr. Pearson mentioned was just recently approved in January of 2021. And this agent was approved specifically for the patient population that was in the primary study that got it approved. So patients who had symptomatic chronic heart failure, which specifically had a reduced ejection fraction of less than 45%. And they either had to have a recent hospitalization or they had to have a need for outpatient IV diuresis. So the goal then with this approval of this drug is to reduce the risk of CV death and heart failure hospitalization, which was the primary outcome of the study. This drug comes from a new mechanism of action, or a new drug class for heart failure. So the mechanism of action is soluble guanylate cyclase, or SGC stimulator. And I want to show you that on this graphic here, which comes from Circulation. So there are a lot of things that play into a patient's decline and their heart function after they're diagnosed with heart failure. One of the things that can play a role is nitric oxide, which the levels in patients with heart failure are often lower. And patients with reduced ejection fraction heart failure may also have impaired SGC activity. So you can see in the red circle there, this is the mechanism of this drug. So it's a stimulator of the soluble guanylate cyclase, which then allows the levels of cGMP to be increased. Now you might be thinking, I've already heard of that before for a drug action, and yes, that's true, because the PDE5 inhibitors, which are for erectile dysfunction or pulmonary hypertension, are also going to impact the cGMP levels. And so you can kind of see that to the bottom of that red circle, where the PDE5 inhibitors are going to increase cGMP by preventing the breakdown to cyclic GMP. Why do we need more cyclic GMP in patients who have heart failure? Well, it helps with vasodilation. It helps potentially with preventing remodeling effects and quite a few other things that are positive in that cardiac patient. Now, we don't use PDE5 inhibitors in patients with heart failure specifically for that, but this mechanism of action has been shown to have positive effects by stimulating the S-guanylate cyclase pathway. So how is this agent used? Well, it's starting at a low dose, 2.5 milligram once a day with food, and it's titrated every 2 weeks, similar to other drugs that we use for heart failure, and we titrate based on preventing adverse events. So the target dose is 10 milligram once daily, but patients are started on 2.5, then they go to 5 milligram, and then they go to 10 milligram. And the reason that this dose is titrated is because this medication as a vasodilator can cause hypotension. So we want to make sure that our patients are able to tolerate it when they're initially started on it. A lot of times new drugs now are being evaluated to see if the tablets can be crushed or given with different food. And this tablet can be crushed and mixed with water immediately before administration. So that is a little bit of extra information that might be helpful for our older adults. Vericiguat has very little cytochrome P450 activity or cytochrome P450 need for metabolism. So we're lucky because in older adults, phase 2 metabolism, which is often glucuronidation, is not impacted by age. So this drug, in terms of older adult hepatic metabolism, should not be an issue. Also, it has been studied down to an eGFR of 15 mils per minute per 1.73 meters squared. So in the product label, it mentions that you do not need to dose adjust in patients with reduced kidney impairment. However, I put monitor on here because in the pharmacokinetics studies, there were a couple of different studies that were done, and one of them showed quite a large increase in the AUC when patients did have an eGFR that was closer to that 15 mark. So I would recommend monitoring for hypotension. In terms of tolerability, this drug actually is pretty well tolerated in clinical trials, and it doesn't really have many drug-drug interactions because of the lack of the cytochrome P450 issue, or even it also doesn't have PGP issues. So when we think about drug-drug interactions, it's mainly pharmacodynamic. So the product label recommends avoiding with PDE5 inhibitors like sildenafil, vardenafil, tadalafil, and that's really due to the pharmacodynamic effects of increasing the risk for hypotension. Once we do have other agents on the market, it shouldn't be used in combination with other drugs that work in the same pathway, so avoiding use with other SGC stimulators is recommended. Probably the least helpful information for you at this particular drug is that it's contraindicated in pregnancy, but most of our patients in the geriatric realm are not going to be pregnant. As I mentioned, it's well tolerated, so the side effects that we primarily would be seeing and expecting to monitor for would be hypotension. In the product insert, it mentions 16% hypotension, fairly similar to the placebo incident rate as well, a little bit lower in the clinical trial that I'm going to talk about. And then anemia is also mentioned at 10% rate. Now, we know that patients with heart failure often have concomitant iron deficiency anemia. So this is something that I think needs to be explored a little bit more. There's not really a known mechanism for why this drug might cause anemia as a side effect, but it was increased compared to placebo, although there was no statistical analysis provided. When we think about anemia, it could be due to bleeding, for example, but this particular drug does not affect bleeding rate. So again, it's really unknown at this point why anemia might occur. So I'm going to take a look at just the primary study that was involved in getting this drug approved, and that's Victoria. This was recently published in the fall of 2020 in the New England Journal of Medicine and included over 5,000 patients, as we typically see in studies of HFrEF. Patients in this particular study needed to have class 2 through 4 New York Heart Association class of HFrEF, the ejection fraction needed to be less than 45%, so a little bit higher than some other studies that we've seen in heart failure. And patients either needed to have a high BNP or a high NT-proBNP. The difference between this clinical trial and others that we may have seen is that these patients needed to have a recent decompensation of their heart failure. And that was defined as either having a hospitalization for heart failure symptoms within 3 to 6 months or a need for outpatient IV diuresis within 3 months. After that time frame, they were initiated on vericiguat 2.5 milligram titrated up to 10 milligram or placebo. And they were in the study for a median of 10.8 months. So a pretty short study compared to some other durations that we might see in heart failure studies. The primary outcome of Victoria was a composite of CV death or first hospitalization for heart failure. When we look at the baseline characteristics, this is always important to look at in terms of age and what type of patients these patients were, what were their characteristics of their heart failure. And in general, there were older adults in the study, but mean age 67 years. They did not report the percent of patients that were over 75, for example. So I'm not able to give you that information. The majority of the patients in this study were men. A little over half were white. They did have quite a few patients that were non-white though. So 23% were Asian and 5% Black. 2/3 of the patients in the study were enrolled within 3 months of their index hospitalization. So that's just to give you a time frame for, they were pretty acute still. They hadn't been managed for 6 months, for example, after their hospitalization and were more stable. So they were a little bit sicker type of patients. 40% of them were in New York Heart Association class 3, so more symptomatic type of patients. The mean ejection fraction was 29%. And when we look at heart failure studies, we always want to look at, are they on standard of care that was at the time of the study? Were they, being treated appropriately at baseline with drug therapies? So 60% of them were on triple therapy. This meant a beta blocker, a mineralocorticoid receptor antagonist like spironolactone, and an ACE, ARB, or Entresto. So Entresto is sacubitril valsartan, which is a neprilysin inhibitor and an angiotensin receptor blocker. In general, 15% of the patient population were taking that agent. And I bring this up just because we have some new recommendations, an expert pathway that were published by the ACC in January, and that pathway recommends Entresto as first-line preferred therapy for HFrEF. So when we look at what these patients were taking in the study, 60% of them were on what we would consider standard of care. Looking at their baseline blood pressure, they were pretty well controlled. So a mean systolic blood pressure of 122 millimeters of mercury and a heart rate of 73 beats per minute. Interestingly, about 1/3 of them had either an ICD or a pacemaker or both. Looking at the primary outcome, again, this is a composite outcome of death from cardiovascular causes or first hospitalization for heart failure. This was statistically significant. And you can see on the right-hand side that the curves start to split around 8 months. So when we're thinking about time to benefit, this medication did take several months to really differentiate between placebo and vericiguat. The event rate was fairly high, so 35.5% in the vericiguat arm and 38.5% in the placebo arm, with a hazard ratio of 0.9, so only a 10% reduction with drug therapy compared to placebo. And these results were driven by the heart failure hospitalizations. Looking at secondary outcomes, all of these favored vericiguat, but only a few were statistically significant. So first hospitalization was included in that primary outcome. That wasn't statistically significant on its own, but total hospitalizations for heart failure was statistically significant. So I'm just listing them there, a 9% reduction with drug therapy compared to placebo. And then all-cause death versus CV death, plus that first hospitalization for heart failure was also statistically different than placebo, again, a 10% reduction. When they looked at subgroup results, I just wanted to point out that there were some significant hazard ratios when we looked at one patient population for another. So for example, who might be more likely to benefit from this drug therapy? And what was apparent in the subgroup analysis was that the younger patients were more likely to benefit potentially. So when they looked at age less than 65 versus over 65, the less than 65 group had a significant hazard ratio while the above 65 did not. And then they broke it down 75 or less, and the less than 75 group had the significant hazard ratio versus above 75. Those who didn't use sacubitril valsartan at baseline had a significant effect versus those that took it. But again, only 15% of the patients in the study were on Entresto at baseline. So that was probably more just related to numbers of patients. eGFR between 31 and 59 had the significant reduction in events, and then lower ejection fraction patients. So those that were more likely to benefit because they had already low ejection fraction were found in that subgroup analysis. So sometimes, you can use the subgroup analysis in terms of like evaluating your own patient population, and sometimes it's not as helpful. This is pretty typical though for heart failure studies, where we see those that have really severe ejection fraction and those that are younger often benefit more than our older adults who are more complex. Side effect wise, again, this drug was well tolerated, but you can see, as with any study, adverse events are super high. So 80% of people had side effects. Not surprising, they probably weren't related to drug therapy. A third of patients had serious adverse events. So, when they show drugs on TV and they have commercials, this is often what is discussed in terms of side effects. They're very common. However, when we looked at what was actually most likely related to the drug therapy, those were only a few. So symptomatic hypotension was not statistically different between drug and placebo. You can see 9% of patients had symptomatic hypotension. 4% had syncope, again, not different than placebo. 7.6% in Victoria had anemia. And then the systolic blood pressure was reduced compared to placebo. It was between 3 and 5 millimeters of mercury or less. And interestingly, the systolic blood pressure went down with the 2.5 milligram and the 5 milligram, but by the time the patients had reached the 10 milligram dose titration, their systolic blood pressure had gone back up to baseline. So it indicating that we really need to be most careful monitoring the patients for hypotension in that first month. And then after that, they may normalize back to their previous blood pressure. So where does Verquvo or vericiguat fit? This is difficult because it is an event-driven drug versus more instituted for a chronic heart failure patient. So when we look at the new ACC recommendations, and this is an expert pathway, expert opinion pathway versus a guideline per se, but sacubitril valsartan is preferred first-line therapy for patient in this recommendation, or patients can be on an ACE or an ARB plus an evidence-based beta blocker. And then after that, it really depends on the patient's symptoms. So again, this is chronic heart failure management. They may be initiated on an aldosterone antagonist like spironolactone. They may be initiated on an SGLT2 inhibitor like dapagliflozin. They may be needing their diuretic titrated. They may be initiated on hydralazine isosorbide, dinitrate, or we even have ivabradine as another option. So I don't know that vericiguat would actually fit into this pathway per se, because this is more for a patient who hasn't immediately been hospitalized. And when we think about event-driven therapy, sometimes patients are hospitalized and we realize they're not on guideline-directed therapy at all. Maybe they're just on an ACE inhibitor. And so they're initiated on a beta blocker at that hospital after the hospitalization. So it's difficult really to know where this drug might fit in, but it is another option that is now FDA approved for patients with HFrEF. Looking at some cases, we have a 73-year-old man with class 2 HFpEF He's recently hospitalized with an exacerbation, and he's taking sacubitril valsartan. So he looks like he might be a reasonable patient for vericiguat. However, he has preserved ejection fraction. So he would not meet the study criteria, which means he also doesn't meet the FDA approval. However, vericiguat is being studied currently for HFpEF. So this study has been going on since 2019, and we should have some results in the next couple of years for this particular agent in the HFpEF population. The next case, 84-year-old woman with chronic class 1 HFrEF taking a diuretic, ACE, and beta blocker, is really not symptomatic enough to be able to take vericiguat. So she hasn't been hospitalized recently. She doesn't have symptoms that are impacting quality of life as much, and she would not meet the criteria for this drug. The next patient, a 68-year-old man with class 2 HFrEF, hospitalized 3 months ago for heart failure and still symptomatic on a diuretic, ARB, beta blocker, and a mineralocorticoid receptor antagonist like spironolactone, would fit the study criteria. So in this case, he would be a candidate for this particular drug, vericiguat. However, he would also be a candidate for other drug therapies. So we would be needing to weigh the pros and cons and the cost potentially of other drugs like dapagliflozin as well. And then we have an 89-year-old woman with class 4 HFrEF, recently hospitalized and transitioning to hospice. So while she might meet the criteria for the study and the FDA approval of vericiguat, transitioning to hospice likely means that she has a life expectancy of less than 6 months. And that means that she probably would not benefit because the time to benefit looks like it's about 8 months for this particular agent. All right, I want to go through a few additional updates and then we'll take questions. One thing still related to heart failure is that in February of 2021, Entresto, or sacubitril valsartan, had an expanded approval for their indications for heart failure. And I probably should have said I have no disclosures in terms of I have no conflicts of interest with drug therapies. I've been mentioning Entresto quite a bit just because those are the drugs that I'm talking about today, but I have no financial relationship with any drug therapies. So I want to mention this because Entresto's expanded indication includes its ability to reduce the risk of cardiovascular death and hospitalization for heart failure in adult patients with chronic heart failure, noting that the benefits are most clearly evident in those with a low ejection fraction. So what this has been translated to is an approval for HFpEF, which, and I put in quotes approved because HFpEF is not actually mentioned in the indication, but the indication is based on the PARAGON-HF study, which was a HFpEF study. So you may have seen this in the media. We do see, again, the Entresto in the HFrEF guidelines being the preferred treatment initially for patients. And we have no drug therapies that are FDA approved for HFpEF. So this is, while not directly approved for it, is really the only drug therapy that we possibly might have in terms of a light approval. So let's look at the PARAGON-HF study just a little bit. So this was a direct comparison between sacubitril valsartan and similar dosing of valsartan monotherapy in 4,800 patients with class 2 through 4 heart failure, an ejection fraction above 45%, so opposite of the previous study that I just talked about. They had to have a high BNP, which we know doesn't differentiate the type of ejection fraction heart failure, and they needed structural heart disease. And these are the kind of patients that we often see in geriatrics, more so than those with this really severely reduced ejection fraction. The average age was older than, again, because this is more typical of our older adult patient population. 18% were non-white, 52% were women. 77% had more milder symptoms, were in class 2. The average EF was 58%, and they also had a pretty reasonable systolic blood pressure at initiation. Their meds, again, we don't have standard of care treatments for HFpEF, included diuretics at 96% of the patients, 86% were taking an ACE-ARB, 80% were taking a beta blocker, and 25% were taking a mineralocorticoid receptor antagonist. You could probably call that standard of care because, again, we don't really have good evidence for any particular drug therapy in HFpEF. What we try to do is treat their hypertension, so that might have been the ACE and ARB. We treat their AFib if they have it, that might have been the beta blocker. And then we try to use diuresis at low dose to treat their symptoms. And there is a study, TopCat, looking at spironolactone, which showed some reductions in heart failure. So in heart failure hospitalizations. So when we think about spironolactone, some patients with HFpEF are treated with spironolactone based on that TopCat study. The primary outcome of PARAGON-HF was CV death and total heart failure hospitalizations. So pretty similar to the primary outcome of the Victoria study, which I just talked about. In terms of results, though, they were not statistically significant. So there's really only a trend in the primary outcome. You can see it came really close to statistical significance with a rate ratio of 0.87, but a p-value of 0.06 and the confidence interval crossing 1. There was also a trend in heart failure hospitalizations, again, came right up to the 1.0. But what was interesting was there was a significant increase in the adverse events. So Entresto caused more hypotension versus valsartan and more angioedema, although low numbers in general, but less hyperkalemia and less worsening of the renal function in the patient population. And that's pretty consistent with the previous Entresto studies. We see less hyperkalemia and better kidney function. So it is possible that we may be able to tailor the therapy to those kind of patients. In the subgroup analysis, females tended to benefit more than men, and those with a low ejection fraction, less than the median of 57%, also were more likely to benefit. In addition to that, I don't have it on the slide, but those with an eGFR less than 60% were also more likely to benefit than those with a higher eGFR. So those are some of the things that we can look at to try to tailor this therapy for our patients. Just a quick review on Entresto. It is, again, 2 drugs, sacubitril, valsartan. You may or may not start this in your patient's cardiology often starts it, but it does need to start at a low dose, especially if you're converting from a lower dose ACE-ARB therapy or if they previously were not on it. And therapy is titrated up with monitoring. One of the most important things is if they're already on an ACE or an ARB, you have to stop that ACE inhibitor 36 hours before you switch them over to sacubitril valsartan. The last drug I want to quickly mention is Gemtesa or Vibegron. This drug was approved in December for urinary incontinence, and it's really just a Me Too drug. So I don't have very much information on it, but it's a 75 milligram once daily beta-3 agonist. So similar to mirabegron. When we look at side effects, though, it's a little bit better tolerated in theory than mirabegron. It doesn't have very many drug-drug interactions. Its efficacy is pretty similar. And so differences from Gemtesa or Vibegron to mirabegron is that you can crush these tablets where you can't mirabegron. There's no dose titration. There's no renal dosing or maximum dose. There's no blood pressure increases to monitor for. But it doesn't have data specifically in older adults like mirabegron does. It's not FDA approved in combination like mirabegron. But it is a new option for our patients with urge urinary incontinence or overactive bladder, and it will be available in April 2021. So starting this month, we may see this drug therapy in our pharmacies. So in conclusion, Scott's giving Remdesivir a thumbs up for its therapy for COVID. And we're giving a thumbs to the side for some useful agents potentially, but probably not going to make huge changes in clinical practice quite yet until we have more evidence or we're able to evaluate the cost of the other 4 agents. At this point, I will stop sharing my screen and we're happy to take any questions. So Scott, it looks like there were some questions about in the box about remdesivir.
Yeah. So first question I saw, so with remdesivir being an antiviral, would it be more useful early as late effects are anti-inflammatory? And yes, there is actually some evidence that starting remdesivir sooner after symptom development may be more effective. One study actually showed, I believe, if it was started within 9 days of symptom onset, there appeared to be mortality benefit compared to patients who were started later on. So that is a potential consideration with remdesivir. And then I think the next question also related to my section. So bempedoic acid side effects on muscles, muscle function, pain, cramps. So that's a good question. Something I didn't touch on with the Clear Harmony trial that specifically looked at adverse events. They really didn't show any differences between bempedoic acid and the placebo group when it came to those individual muscle complaints. And overall, when they looked at discontinuation due to muscle complaints, rates for that study, it was about 2% in each group and not a significant difference. And also in the statin intolerance studies that, again, I didn't touch on today, but with those studies, it does appear that in patients who have not tolerated statins, they do appear to do pretty well with bempedoic acid. So it definitely doesn't appear to have the same risk of those as statins do.
All right, it looks like another question was in the PARAGON study, what is meant by structural heart disease? And I don't have the definitions were not in the original study. I can look that up, but I'm guessing it probably means left ventricular hypertrophy for most of those patients, which is fairly common in patients with HFpEF. And then the cost of Vabegron, I don't have. It may be available in the next month, but I'm guessing it will be competitively priced with that of Myrbetriq or Mirabegron. One thing that may be coming with that is that with having 2 agents on the market that are beta-3 agonists, it's possible that there may be a little bit more competitiveness for formulary options. And what that might mean is that we may be needing to follow up with you guys in the future about what is on particular Medicare Part D formularies. Do they have Myrbetriq on formulary, or do they have Gemtesa, the new drug therapy for OAB?
All right, well, we are at time. Thank you, Sunny and Scott, so much for another great presentation, and we'll look forward to having you guys back next year. So, thanks, everyone.
All right. Thank you.
Yeah.